So I'll be presenting before you a novel technique of closing an asymmetrically large macular hole by a differential flap. I call it DIMS, a differential ILM flap macular hole surgery. The treatment options for closing a large macular hole are inverted ILM flap, a petaloid technique, or the Cabbage closure technique as we had described it in 2017, a free ILM flap, lens capsule or amniotic membrane, or an autologous neurosensory retinal free flap. This was the Cabbage closure technique described by us in 2017. So here is a 61 years old female with a blurred vision of 1 year duration who is non-diabetic and non-hypertensive with a visual acuity of 6/36, and there's a large symmetrical macular hole. I call it symmetrical because the arms AB and CD are similar. The angle alpha and beta are also similar. Hence, this can be closed by a petaloid technique with the flaps being equal in size. When they cover the macula, they exert a large centripetal force covering the macula. So let's have a look at the surgery. This is a standard vitrectomy is done. The vitreous is removed assisted by triamcinolone, which helps us to induce PVD and remove the entire vitreous cortex. Once the vitreous is completely removed, we stain the ILM with a dye which is either ICG or BBG. Here it's stained with ICG. The inverted ILM flaps are being created. The second flap has been created now. And you can see that every flap has a retinal surface and a vitreal surface. And one flap covers the vitreal surface, covers the other flap's retinal surface. Excess ILM is removed and a fourth flap is being created which covers the third flap. This is followed by a fluid air exchange, followed by a fluid air gas exchange. So this is the post-operative picture. The macular hole is nicely covered with the visual acuity improving to 6/24. You can see the remnants of the ILM over the closed macular hole. So this was a symmetrical closure using the petaloid Cabbage closure technique. So now let's look at asymmetric large macular hole. This is a 56 years old female with blurred vision for 3 months, has a grade 4 large macular hole with slanting neurosensory edges with a visual acuity of 6/60. If we close it by normal method of petaloid closure, the probable result would be that the hole will close on the surface but not close underneath, leaving behind either an inverted L-shaped open area or the inverted V-shaped open area. Hence we decided to close it in a different manner. This is what shows that why the hole is asymmetric, because the arm AB and ED are not of the same size. Similarly, angle alpha and beta are not similar. Hence we created two flaps, flap 1 and 2, which are based on the nasal edge of the macular hole. These are large flaps which are covering the macular hole and going onwards towards the temporal side. The temporal third macular flap is created, ILM flap is created, but it is removed. This is a superimposition of these flaps onto the actual fundus image. You can see here flap 1 and 2 starting from the nasal edge of the macular hole going on to the temporal side covering the macular hole. This is the video which shows how this was done. A standard approach where vitrectomy is done assisted with triamcinolone, which helps us in reducing the PVD, and once this is done we stain it with BBG. So once BBG staining is done, we are inverting an ILM flap. We start from the superior border and cover the nasally cover the macular hole, create a second flap which covers the first flap so that the retinal surface of the second flap covers the vitreal surface of the first flap. Then the excess ILM around it is removed. This helps in reducing the tangential traction. Similarly, the temporal flap which was to be put is also removed, and the flaps we ensure that the flaps stick to each other. This is followed by a fluid air exchange, which ensures that there is no fluid remaining onto the disc surface, and this is done with using a soft tip cannula till we achieve a completely dry retina. And we also ensure that the flaps have not moved and are maintaining the position as was done once they were inverted. Having done this, we remove the cannulas, and this is followed by introduction of C3F8 gas with a gas air exchange, and we target for a 14% C3F8 non-expanding mixture in the vitreous cavity. Remove the cannulas and ensure that there is no leakage. This is post-operative course, day 1, day 7 and post-operative week 8. Visual acuity improved to 6.9 with a good closure of the macular hole, and the result was really dramatic and the improvement was very satisfying. The Cabbage closure can be with the symmetrical flaps, as is the photograph on your left, and on the right is an asymmetric closure of the macular hole, causing the Cabbage closure of the macular hole with the asymmetrical flaps, the retinal surface of one covering the vitreal surface of the other flap. So the take-home message is that the inverted ILM flaps close in the Cabbage technique by a Velcro mechanism. Additionally, ILM leaves may contract, generating a tractional force out of the edges of the macular hole, and this concept has helped us in closing an asymmetrically large macular hole by exerting traction from the nasal edge of the macular hole to the temporal edge. The domes of the leaves of the ILM create a closed space for the macular hole, helping the RP pump out fluid. It is critical to spend time on the table before and after fluid gas exchange to ensure that the ILM flaps remain juxtaposed. It is also important that the patient must lie prone immediately post-operatively and lie for 10 to 12 hours per day for 10 to 12 days. Thank you for your patient listening.